Our next speaker is Joy Moeller. All right, Joy is actually a dental hygienist. All right, she's an author and formerly an associate professor at Indiana University. Is that correct? Yes. Okay. She's worked as a myofunctional therapist for many years and currently has a private practice in Pacific Palisades, California. All right. She is a founding lecturer with the Academy of Orofacial Myofunctional Therapy. All right, and a founding board member of the AAMS. Joy wrote a chapter in sleep medicine clinics, a chapter in sleep disorders in pediatric dentistry, published in 2019, and a children's book on tongue position, as well as many published studies and other chapters in textbooks. She is currently on the board of the American Academy of Physiologic Medicine and Dentistry, a multi-disciplinary medical and dental group interested in airway problems, where she received a Lifetime Achievement Award in March of 2015. All right, Joy has lectured worldwide and was invited to speak at Grand Rounds at the Mayo Clinic in Rochester, Minnesota, and to Stanford's Sleep Residency Program in 2020, or in 2022 at the Pankey Institute. Yes? Okay. All right, she currently teaches with the Palo Alto School of Sleep Medicine and taught for 7 years with UCLA Dental Sleep Postgraduate Program, as well as an ongoing guest speaker at USC Dental Hygiene's program. All right, so please welcome to the stage, Ms. Joy Moeller.
It's a real honor to be here today, especially because there's a lot of newbies. And my background is a dental hygienist, but I had family issues with airway problems. First of all, myself, my husband, and my son, who they wanted to do brain surgery, exploratory brain surgery on him for his headaches and TMD problems. Lucky for me and for him, I started working in a holistic dental office in Cardiff, California. And I don't know if Dr. Kennedy is here, but years ago, I lived in San Diego for many years and worked with him on some projects in nursing homes. But my background, though, to help my son is what got me here today. And he turned out to be an amazing human being. Thanks to all the holistic treatments. The dentist I worked for had taken a class with Dan Garliner, told me, your son's tongue is in the wrong place. I had never heard of anything like that before. And so we put it in the right place and had Viola Fryman do cranial osteopathy with him. And my boss did airway opening, and his life changed. And that's why I'm here today, so that all of you can help your patients get where Brian is today. Some disclosures. I teach with the AOMT, the big disclosure, which is an organization that teaches people how to do myofunctional therapy. And I know we have some students here. Raise your hand if you've been through my class. Gosh, only one, two people. And I know other people have had their hygienists come. So, and I'm on the board of the AAPMD, which Michael and Howie started with Bill Hang and Kevin Boyd and a whole bunch of us. And I also teach with Palo Alto from when I spent some time at Stanford, and I still teach with them. Mostly teach pulmonologists what we do. So I want the learning objectives is so that you can identify what these disorders are and why it's important to help your patient, and also go over some of the science. And I know I gave a handout to everyone with all the current science, a lot of it. So what is myofunctional therapy? It's neurologic re-education of the orofacial muscles. What we do is a series of therapeutic techniques designed to eliminate habits, normalize breathing, develop ellipseal, toned lips, a palatal tongue rest position, both anterior and posterior, work to isolate, activate, and elevate the back of the tongue. It's all about the back of the tongue, genioglossus muscle. Tone the pharyngeal muscles, and we work on posture training and correct swallowing and chewing. So these are just some of the signs and symptoms that we see. And I think the one up in the corner is probably the upper right corner, the tension around the mouth when people swallow. It's pretty easy for a dentist to just put a little water in their mouth and watch them swallow. And look at the tension around there when they swallow. They're using their lips to stop the water from coming out, instead of using their tongue muscles to push it back. I think that's probably the most overlooked part of diagnosing a problem. Also the overdeveloped mentalis muscle, the open bites, forward head posture. Why is the head forward? If your head weighs as much as a bowling ball and your tongue weighs 3 ounces, if your tongue is resting forward, it's just enough to pull the head forward. And a speech pathologist from Portugal put this together so people understood it's not just the tongue. It's all these muscles interact. They're different from other muscles. There's over 58 different muscles that move and change things together. It's like one big muscle. So what we do is disorganize the muscles and then repattern them. We isolate and activate all these muscles. And the tongue is huge. Everybody has seen this where it's big. I recently heard Professor Takashi Ono speak at the AAMS Congress that we had. The most interesting thing he said in his whole lecture was the tongue is actually a respiratory organ. People don't understand that, but the diaphragm and the back of the tongue work together to get the maximum amount of air flow. So if the back of the tongue isn't working, the diaphragm's not going to work as well. Myofunctional therapy was first discovered in the United States by Alfred Rogers, who was an orthodontist, who wrote this in 1918 about how important the muscles are. And we still use some of these exercises today. And he said it was their duty, an orthodontist, in order to perform his work well, to strengthen all surrounding tissue that has to do directly or indirectly with the development of the face. Unfortunately, he was criticized for many years, and before he died in the 1950s, he was given an award. But the truth of the matter is the newborn palate is as soft as a drum, and it may be changed by forces of the tongue. I heard George Meredith talk in 1987, and he had this diagram of how airway problems develop. He was an ENT from Washington, D.C. Very interesting. The AAGO just had an article about him in the last journal I just got. It's interesting. But it's all about how the tight freenums, bottle feeding, pacifier use, sippy cups with spouts, any spouted bottle can cause that tongue to go awry. People used to drink out of streams from their hand. You know, they never had little bottles that squirt things in people's mouth. All those things deform the mouth and eventually lead to sleep apnea, TMD, and orthodontic relapse. And what we do is to try to reverse that system. So all these things, we're deforming mouths. These are some books that I have in my office that I had to take a picture of it going into the history. Hal Huggins wrote this book, Why Raise Ugly Kids, that I read in the 1980s. And in it is just so much information. And he talked about Harvey Stallard, who did a study in the 1920s, which talked about if you sleep on your face, the tooth buds are removed. So many kids sleep on their stomach or sleep on their face. And all that pressure causes a lot of problems. And there's also Harold Gelb's book. He has a chapter on myofunctional therapy. Dan Garliner, who I originally studied with. Morgan's book on TMD. There's a lot of information in there. I don't know if anybody has that book. Anybody have that book in there? It's an amazing book. And also the Masters of Functional Orthodontics. And the New Trends is a new book that Licia Cocciani-Pasquet and somebody from Italy wrote. It's very good. Okay, so the problem has always been a lack of collaboration. There were these doctors that had a functional approach and the other doctors who had a structural approach. And they would fight with each other. My way is better, my way is better. But the truth of the matter is we all have to come together and collaborate. That's the only way we're gonna save our civilization. Because I've been in the field for 40 years, and I've seen it go down, down, down. More and more babies have problems, children have problems. I have a 5-year-old patient, they live in Sarasota. If there's anybody here from Sarasota that would like to help this little boy, they're coming tomorrow. He's in a CPAP. He's had his adenoids out. His adenoids grew again. The CPAP has pushed his maxilla back, and the mother said she's looked everywhere for somebody with airway background. So if anybody knows anybody close to Sarasota, I'd really appreciate it, because he's a really nice little kid. So are we deforming our children? Because I see this a lot, either with tongue thrusting, or with mouth breathing, or with thumb sucking. And, you know, this is possible with myofunctional therapy. And Karen Bonnet, I really like this lady because she devoted her whole life into doing research on children's airway and behavioral problems and learning disabilities. If it's not treated early intervention, I start treating patients early, like 2.5, 3 years old. Get them in and get them fixed. At least do the best you can, and then the orthodontist can help. Also, I don't think, if anybody has not seen this diagram, a normal tongue rest position is your tongue is up in the palate, the whole tongue. You take a bite of food, your tongue pushes right up to the premaxilla area to push the food down. And everybody's happy, right? You chew at least 20 times. Chewing isn't lost art. Kids want macaroni and cheese and chicken nuggets. They don't want to chew anything. But in an abnormal swallow, or abnormal tongue rest position, air is trapped above the tongue. And the child takes a bite of food and swallows air. It's called Orofacial. And that gets confused with a lot of issues. The GERD and all the belly aches, the child not wanting to eat, becoming a picky eater. And when they mouth breathe, they can't smell. So they just want to put some food in and not chew it, get it in to shut their parents up. They don't really care if they eat or not, unless it's sugar, tastes sweet, then they'll eat it. But also, if you don't chew, talk about stomach problems. If you're not chewing your food, you're missing all the digestive enzymes, because behind the masseter muscle is the parotid gland, which is your major enzyme producer. So I'd say probably a third of my patients that come in, my adult patients, are taking enzymes because they don't chew. And they don't chew because it hurts. So it's a challenge. Also, one thing people don't realize about that cute little thumb in the mouth that pacifies it. I've had so many pediatricians tell me that's normal. Thumb sucking is normal because they need to pacify themselves somehow. And I say, no, they're pushing the mandible back. It's not that they're bringing the maxilla forward, they're stopping the growth of the mandible. And it's airway. So myofunctional disorders are related to many other things too. It's not just crooked teeth. It's all of these things: orthorelapse, posture, speech and language problems, nutrition, they're not digesting their food, learning behavior issues, orofacial pain, obstructive sleep apnea. So what happened in this case? This is a patient I treated a long time ago. He's become a real close friend of mine. I didn't treat him in 1959. He brought in his pictures for me from all the way. He kept everything. At age 13, he said he was bottle fed. He sucked his thumb. He started ortho, he had bicuspids extracted. At 17, he said his teeth were straight, but his nose started beaking. And you could see his mandible was protruded. At 24, his bite opened again, and nobody saw the frenum. There we call that the Eiffel Tower. At 28, he had a rhinoplasty, a chin implant, deviated septum repair. He had tonsils and adenoids out at 28. And he thought he looked a lot better after all that. However, at age 43, he had sleep apnea and temporomandibular joint disorders. Then he had a UPPP. That's where they cut out the Mallampati score. And at age 48, chronic fatigue, depression, sleep meds, gained weight. His teeth were moving again. Chronic neck pain. And he found Bill Hang. And they did an amazing surgery with Dr. Wolfert and moved both jaws forward and helped his airway, right? But what happened, just like what happened at Notre Dame, they looked in the wrong place for a lot of issues there, and it took 30 minutes for them to actually discover where the fire was after the first alarm, before they alarmed the fire department to come. So in 2009, he started myofunctional therapy because Dr. Hang thought that would help too. It's a last resort because he still wasn't sleeping very well. And he brought his pictures in, and I saw, and I missed it too the first time, he had a tongue tie. So we had that released. And he started feeling better. He started sleeping. And his posture changed. And here he was. He came in. I'm not going to show you the whole video because he goes on and on in the video. But he dyed his hair because he wants to go on Oprah at this point, when Oprah was still doing his thing, because he was so happy because he was sleeping all night and his tongue was in the right place. And he felt like $1,000,000. He's actually a judge today. So, myofunctional therapy, this is one of the studies, a meta-analysis that they did, Stanford and other schools, proving that it helps 50% in adults reduce the AHI numbers and 62% in children, and snoring, oxygenation, and sleepiness outcomes all improved. And there's now 3 meta-analyses. Dr. Camacho has been involved in them. So let's look at this. This was a picture from the TMJ Morgan's book. The roof of the mouth is the floor of the nose. And the tongue is actually an organ. It's not a muscle. It has 16 muscles in it. And if they're all isolated and activated and working properly, it can cause a widening of the arch by itself, especially in children. But even in adults, it helps. Not as much as Dr. Hain can do it, but the combination of both working together. Because we know that a high narrow palate is one sign of sleep disorders. This is a picture I put in. We have a coffee clutch on Saturday morning for all of our students. And it's on Zoom now. We teach all virtually. And this is one of the students who was a speech pathologist in Poland. And we have students all over the world. And she started in October. And she showed pictures on our Zoom meeting, and I got her permission to show it. She took the course, the myofunctional course, not to treat her patients, but to treat herself, because she had such bad jaw pain and sleep disorders, and nobody in Poland had been able to help her. So these pictures were taken in February, from October to February. She did get her tongue released. Look at how her palate changed. This is nothing that was photoshopped or anything. And look at how her mandible came forward. This is just with the frenectomy and myofunctional therapy. Now, she's not 100% better, but it's a hell of a lot better in 4 months, right? I was blown away. I was like so proud of her. She had to drive 2 hours to find a doctor that would do the tongue release. And it was the first time that he did it. And she said it was so painful and so upset. It was so horrible. But she was so happy she did it because it reduced her pain. It's a true story. She'll talk to you if you want to. So Malampati score, we all know Dr. Malampati was an anesthesiologist. He scored the opening. And we now know that when the soft palate collapses, that's one sign of sleep apnea. So it can be changed with myofunctional therapy. I have my patients look at themselves and work on exercising the muscles of the soft palate and the pharyngeal muscles. Okay, it's all in there. It's all in our courses. And Mayor Krieger, who was the dean of Yale, and he wrote the Bible for sleep medicine. There's now 2 chapters on myofunctional therapy. So the medical profession is understanding the value of all this, but they're not sure how to approach it on a university level yet. Still in the baby stages. So some articles talk about relapse of airway surgery. And this is what I see a lot of. The allergies treated, the airway surgery was completed, but nobody changed the behavior. Nobody changed the muscle patterns of those 58 muscles of the head and neck and those 16 muscles of the tongue itself. And I see this a lot, open bites that develop and the head coming forward. Well, these two doctors in Italy, the Olivis, did a study on lingual frenectomy and myofunctional therapy. Actually, they're seeing one of my patients now that lives in Rome. They're from Rome. But this is possible in 4 months with myofunctional therapy and a lingual frenectomy. The tongue is the rudder for the spine. It's connected to the highway bone in your neck. Again, if it's resting down or forward, it's enough to pull the head. And that develops all kinds of scoliosis problems, head and neck, and lots of work for the physical therapist, over and over and over again. If you don't treat the cause of the problem, it's not going to hold long term. And then I started seeing a lot of jaw pain patients who had had jaw surgery and relapsed. I've had patients that have had 6 jaw surgeries, or 7. 7 is my top right now. So I got upset about it, and I wrote a chapter, and I put some other people on the chapter with me that this is going to be a textbook for oral surgeons. It's available now on Amazon, by the way. But I wrote a chapter in there with 2 speech pathologists, an ENT, and a physical therapist, Cynthia Peterson. Okay. So this is Lori, and Lori we learned a lot from. She had sleep problems and grinding and clenching.
Teeth are wider.
Wider.
Dr. Lee thinks that my teeth have opened up 2 millimeters. His estimation. He was amazed at the amount
Can you all hear it?
of expansion I got with the force of my tongue. Getting it up there. Good. And yeah, doing great.
Pain that doesn't really bother you.
It does not bother me. It does not nag at me. I'm eating, my gosh, I eat trail mix, almonds. I can chew a little bite of steak here and there.
And you're sleeping well?
I'm sleeping great. I'm able to sleep with my tongue up to the roof of my mouth. And there's a space for it, so therefore I'm not waking up at night chewing on it, trying to find a place. I'm 1 year this week post-op from my jaw joint replacement. Good. I'm doing great.
Good. All right. Well, thanks to you so much. And thanks to you for being such a diligent patient. So that's how she finished. And look at how she started, you know. It's form and function. If you swallow 500 to 1,000 times a day with 4 pounds of pressure, and if all those muscles, those 16 muscles of your tongue are activated and functioning properly, it can change the jaw. It can change the face. So this was not me alone doing this. This is working with an osteopath, a physical therapist. I mean, I had a team. I had the greatest orthodontist in the world, Dr. Hang, and a good surgeon. It was all beautiful, and a great oral surgeon that did the tongue release. So, and she brought in all of her appliances from years of wearing things. So yeah, there's research now showing myofunctional therapy helps with temporomandibular joint problems. Interesting. The Brazilians have done a lot of research on that. And also bruxism. Let's talk about bruxism because Dr. Gell brought up all about the night guards and how there's, they're not so good for some people. They guard the teeth, so the teeth don't break, right? But do they really help the clenching? I look at it like this. Everybody take your tongue right now and push it up to the palate as hard as you can. And you'll feel all the muscles get tight. Try to clench. It's hard because the tongue is balancing that force. I say you put something in there, it's like a horse with a bit. You put a bit in the horse's mouth, the patient's going to clamp even more. A lot of times people clench their teeth because if they move their mandible, the mandible is a floating bone. If they move it to the side, like if they're sleeping on their side, it's going to cause the disc to slip. So they clench to open the airway, yes, but also to stop the pain. So I've just worked with a lot of bruxers and they improved. So let's talk about frenuloplasty or frenum release. I did this study with a bunch of other people and they were more than half were my patients. But we came up with a different grading scale to how to determine a tongue release. There's such a thing now as a posterior tongue tie. And people that think their tongue is free, they actually, the back of their tongue is restricted. So we have to look at that. So these restrictions don't allow those 16 muscles to work well, to stabilize things. And a posterior tie will show a little, like a pull down in the middle or a little dimple. And these restrictions affect the entire body because there's this whole system called fascial tissue that runs throughout the whole body that's affected by your tongue. And scalping tongue, it's the tongue is pushing into the teeth, right? That's why there's scallops. So if the tongue was pushing up instead, maybe those scallops would disappear. But more important, the lateral border of the tongue is where oral cancer begins. My best friend's husband, Linda Kroll, who some of you might know, she was a famous hygienist. Her husband has oral cancer because he was tongue thrusting for many years and he would never do myofunctional therapy. And it's serious because there's a lot of arteries in your tongue. And it's bad. What about perio? I'm a hygienist. I was a really good hygienist when I was a hygienist, working in this holistic office. I had a lending library of books, sugar blues, and all that, and we did brushing and flossing, and we did all the holistic good things for, stress management. Speaking of stress management, I'd say 99% of my patients right now have PTSD in California from COVID. PTSD causes anxiety. So when people are anxious, the circulation doesn't flow as well. And then the masks are causing them to mouth breathe. And it's just this vicious cycle. I'm hoping it's going to end real quick. But periodontal disease, the tongue is pushing. They're mouth breathing. What are we doing with these people? How many of you are hygienists here? Yay. You got to get them to do myofunctional therapy and teach them how to breathe. And, it can create a lot of similarities to obstructive sleep apnea. But this lady had jaw surgery and it relapsed, and I treated her. And she's better now. She helps us. Bilateral tongue thrust can be anterior, unilateral, bilateral. This is Michael. He wound up getting his scholarship for running. He wanted to go to a good school and his parents couldn't afford it. And you could see how his mandible came forward. He had a tongue release. He did the Buteyko breathing. We incorporate that into the myofunctional program, teach him how to breathe. So what you're feeling now about the therapy, has it helped you? And so how?
I feel like it's really been life-changing. It's changed like almost like the entire function of like the way, you know, I breathe and swallow, you know, everything about my face is like changed. It's been amazing, like I sleep better and stuff, you know.
And you also had the breathing education too, so that was helpful.
You take a breathing, yeah, sure.
Posture, and your physical. So all this stuff, you know, the AJODO, that's the biggest ortho journal out there. Are there any orthodontists here? None. Dr. Hayes. But they don't want to read their own research. Anyway, it's out there. This little girl, she only chewed on one side and only slept on one side. So you can see after 8 years of being in braces, I finally got her as a patient and we worked and she finally straightened out. But this whole thing about sleep position, you go to all the medical things and they say put tennis balls under your back so you sleep on your side. So you sleep on your side, and what does it do to the mandible? It pushes the mandible, and the disc slips. And it also makes deviated septums. It also makes narrow faces. Instead, if you put a brick under the headboard, or you can go to Bed Bath & Beyond and get a bed riser, just do the front of the bed, the headboard. And actually there's research on it now. The influence of head of bed elevation in patients with obstructive sleep apnea. That it's for mild sleep apnea, you can elevate the bed and it reduces the AHI. Why? Because if your tongue is not working, if your tongue is tied, it's going to fall into the airway and block the airway. So until you do myofunctional therapy, it's a year-long program, at a minimum of a year. If you elevate the bed, you can sleep on your back comfortably, just 5 inches, because your tongue will drop forward instead of falling back into the airway and choking you. And you can see what this does when you sleep on your side. You're fighting Mother Nature. This is a boy who had, he's a football player at UCLA currently, and he had orthodontic relapse, but he also had orthognathic surgery relapse. And he had lip ties and tongue ties so bad. Here he is talking about it. I don't know if this will come through. So this is Colin, and Colin, you've been my patient for about 6 months. Can you just tell the doctors here what you think of myofunctional therapy and a frenectomy, lingual frenectomy you had, and also labial?
Yeah, so I've been through the works. I do think myofunctional therapy is very helpful. And I've been doing, so I did orthodontic, like work or whatever, braces, retainers, all that, from the age of like 8 to 18. And it was a nightmare. It eventually peaked when I had jaw surgery at the age of 18, which was just terrible, but it had to be done. And then I started relapsing shortly thereafter. And the reason for that relapse was that I had a really bad tongue thrust. So that's why I started working with Dr. Moeller. Since we've been doing that, relapsing has stopped, and actually my teeth are starting to come together again, which is nice. And also I've just basic, eating, drinking, swallowing, all that. A few things in particular that are really helpful, especially for me. I'm someone who plays football at a college level. I also just an active person. I got a few lip ties removed. I had a tongue tie released. That's all allowed me to breathe a heck of a lot better. It's just improved my life in so many different ways.
Okay. So there are some studies showing that if your tongue is tied, it's a risk factor for maxillary hypoplasia. We're trying to get every baby born in the United States to have their tongue evaluated and released at birth. What a difference that would make. That and breastfeeding alone and not giving them baby food. They need to have food that they can chew. Blenders were developed in 1935. Before that time, the baby would just pick up a chicken leg off the mother's plate as soon as they could sit up. They didn't even have teeth, and they would gum it. They didn't get baby food. So it's coming. And Dr. Guimeda wrote his studies concluding that restoration of nasal breathing during wake and sleep is the only valid endpoint in treating obstructive sleep apnea. Patrick McEwen and I met about 12, 13 years ago, and I was blown away by Buteyko breathing because what it does, it gets the brain to change the way it thinks about air. Like the only way you can breathe is through your nose. I teach my patients your mouth is for talking and eating, your nose is for breathing. So treatment, I just want to talk a minute about treatment. You want to eliminate the habits, make them aware of what they're doing. It could be nail biting, it could be leaning on their face, it could be sleeping on their face. There's an intensive phase, 8 to 12 weeks, and then the habituation and generalization goes on, the maintenance for 12 months in order to ensure that the cellular memory has got it. And sometimes it's longer than 12 months. Sometimes it's 24 months. I do complete treatment, whatever it takes. There's problems with myofunctional therapy. It's compliance. When the team reinforces it, you develop your little team, the team reinforces the success, and then you reinforce they're wearing their appliance or doing the rubber bands or doing whatever the doctor wants them to do, changing their diet or chewing better. I can't tell you how much better it works with the team. The therapist also needs to be dedicated and present because a lot of people have tried myofunctional therapy, but they did their 6-week course or 10 visits. It's not enough. The brain has patterns of memories that need to be habituated. And Garliner said every therapeutic failure is the fault of the therapist, not the patient. First of all, you have to make sure they fit it to do it, but then you want them also to be successful. Otherwise, why do it? And we use technology now, a lot of videos, photos, measurements. I have them bite into pink wax, a medium indicator wax, and then measure and then show them any changes that motivates their video of what they looked like before, what they look like now. And also, if it's a child, the parents need to be on board too. The family needs to be involved. So we treat the cause of problems and with the team approach. We are a very important part of your team. Hopefully every hygienist in this country will eventually find that it's standard of care for them to be treated in their hygiene program to learn how to do this. And thank you so much for making me part of your team, and I'll answer questions later this afternoon. And you can find me, there's my email address, joymoeller.com. People make fun of me because Joy Moeller, hygienist from Flossmoor, Illinois. Thank you very much.